so that it doesn't interrupt the recording, so that the people that they will be visiting the YouTube channel, they will have a better listening of it. All right, so welcome once again. I'm G.k Emmanuel, the CEO of G.k Consult. I'll be your facilitator for the lecture 2. So the lecture 2, we are going to talk about prevention of mental illness. How do we prevent mental illness? How do we prevent mental illness? So we are going to look at prevention of mental illness. We will look at some determinants of normal and abnormal behavior, of which we looked at it in the lecture 1. So it will be very fast and brief. We look at the difference between mental health and then mental illness. We look at assessing the psychiatric patient, so how you assess your psychiatric patient. We will look at thought process, and probably we will dive into some of the thought disorders, if possible. Then we will look at the psychiatric history, how to take history in the psychiatric unit. And then we will look at general nursing care or management of mental disorders. Let's begin. So prevention of mental illness, when we say the word prevention, it's very broad. Initially, when we say prevention, we are only focusing on one aspect, but then in mental health, we've broadened it. So prevention simply means that you are keeping the disorders from occurring. You are keeping it from what? From occurring. For instance, someone who is having a schizo, that's schizophrenia, someone who is having a schizo, we have a situation whereby the person is not having a schizo. He is not having it. It's not like normal. He is not having it. But then you put some measures in place to make sure that the schizo doesn't happen to the person at all. That is one aspect of the prevention. And then also, there will be a situation that the person is having the schizo. The person is what? Is having the schizo. He's having it. But at this point, it hasn't escalated. Okay, it hasn't escalated. So you can put some preventive measures in place so that the patient's schizo doesn't get triggered. It doesn't escalate. The person will remain calm. The schizo won't even set in. The person had to, but you are putting measures in place to make sure that the person doesn't get the schizo. Like the person doesn't, the person's schizo doesn't get triggered. It's just like someone who is having asthma. So that the person's asthmatic attack doesn't get triggered. So you make sure that the person doesn't come in contact with perfume, dust, and those things. It's also a way of preventing. Is that okay? And then also there is the last side of prevention, whereby the person is already having the schizo, but you can put some prevention measures in place to make sure that the schizo doesn't escalate into other things or it doesn't get complicated by other conditions. So basically, we have 3 levels of prevention. We have the primary prevention, secondary prevention, and then the tertiary prevention. So the primary prevention, for this aspect, the public health unit nurses and then the psychiatric nurses, you have to take note of this particular aspect, as well as the other programs in nursing. So the primary prevention is focused on making sure that the patient doesn't get the mental illness at all. Whereas the secondary prevention aims that the patient's mental illness that he's already having, it doesn't get triggered. It doesn't get what? Triggered. Yes, the person is already going into depression. But then we try to put measures in place now. The person is no more depressed. But we have to continue putting measures in place so that the patient doesn't go back to his or her depression state. Then the primary prevention, there are also measures that we put in place so that, or it also aims at not making the person who is already in depression state. We don't want the person to go and commit suicide because that's a complication of the depression. If care is not taken, the person can commit suicide. So we are aiming at preventing complication. So when we say primary prevention, so this is it. Primary prevention, it involves taking measures to remove, change, or eliminate causative factors. before they cause any harm to your patient. For instance, the patient is not an alcoholic patient. Okay, the patient is not what? It's not an alcoholic patient. But this patient owns a drinking spot, and the patient has visited your facility, and the patient is saying that, the reason why my blood pressure is raising is because my wife has actually divorced me, and it keeps me thinking and thinking and thinking. I've been thinking, I don't eat, I don't even go to work. You knowing that the person is having a drinking spot, the next now will come into your mind as a nurse or as a public health nurse or as a psychiatric nurse is that, if I don't rehabilitate these patients, or if I don't relocate these patients, since the patient is having a drinking spot, the patient is likely to go and what? It's likely to go and drink. So primary prevention, the patient is not a drunkard, the patient doesn't drink, but you plan and aim in the primary prevention. You plan and aim in removing that risk factor, which is the spot, which will pose your patient at a risk of becoming an alcoholic patient. That is the primary prevention. So the primary prevention aims at mental health promotion. So there is a month that they normally do mental health promotion. So they are just creating awareness they are creating awareness for everybody to know that, yes, there is mental illness there. Your mental health is at stake. If you do this, it's not good. The people haven't gotten it already, but you are keeping on. You keep on what? Keeping them informed that if you do this, you mentally ill. If you do that, that is primary prevention. And let's look at what goes into primary prevention: education on mental health. So the patient doesn't have, but then you can educate the patient so that the patient doesn't get a mental illness. Genetic and then marriage counseling, so that the couples do not give birth to a schizophrenic child, because we've learned that one cause or one predisposing factor of mental illness is what? A genetic predisposition. So if you have a schizophrenic man and female getting married, you have to cancel them, because they are likely to give birth to a schizophrenic child. So once you do that, you are doing primary prevention, because you are trying to make sure that the people don't give birth to a schizophrenic child. So you are trying to prevent. That's primary. And then guidance and counseling at home, schools and workplace. So you visit, let's say you visit Infantine Senior High School. You visit them. Oh, so if any girl child or girl student who is having, facing problems, personal problems and issues which may impose stresses on the patient, on the person, to the extent that the person might get mentally ill, come so that we counsel you. The person hasn't been mentally ill yet, but then through your guidance and counseling, the person wouldn't get the mental illness. And also premarital counseling. We want to marry. We've gone for counseling. Okay, you both are schizophrenic children, schizophrenic couples, don't marry. Else you're like, once you do that, you are trying to prevent it or remove the predisposing factor. We have education on good and adequate nutrition for pregnant women, so that they don't give birth to patients and babies with mental retardation, and it's also a mental disorder. Poor antenatal and postnatal care and all of those. Now, secondary prevention. Secondary prevention, it involves early detection and treatment of a disorder. Is that okay? So, for instance, if you go into, let's say, community A, and then you go and do health screening in community A, you are trying to what? To detect the condition early, before the condition would get out of hand to the extent that it will become an illness on them. Exactly. So you are trying to detect it. So early and regular screening, home care services, emergency treatment, therapeutic milieu. When you say therapeutic milieu, it means getting a therapeutic environment. And then secondary prevention. It's also, so we are still on the secondary prevention. It also talks about supervision of patients receiving medications. Like we have, You see, the mentally ill, if you go to those of you who have been to the psychiatric hospitals, when they are giving them the medication, they have to go under supervision. Suicide prevention services. So there is this patient who is already depressed. You have to what? You have to try to counsel and guide the patient so that the patient doesn't go and commit suicide. So when you do that, you are doing suicide prevention services, psychotherapy, interventions by community and all of those, crisis intervention and all of those. And then the tertiary prevention. The tertiary prevention. It also involves the reduction or limitation of impairment or disability. But this one, it aims at rehabilitation. And then also the goals of tertiary prevention are restoration of function, limiting progressions, and then preventing complication, like I explained earlier. So you should know that the different types of prevention. So there was a question like that. Which a scenario was given. And then in that scenario, the psychiatric health nurses were doing early and regular screening, and then they were visiting the homes of that particular community to give health education and all of those. So what type of primary and what type of prevention is a psychiatric health nurse using or initiating? So that is why I included this in my slide, because of those kinds of questions. So pay attention to it. Okay. So the determinants of normal and abnormal behavior, we spoke about it in the lecture 1. So the cultural context, historical context, average norm, interpersonal relationship, adaptation and adjustment, and then we have personal growth and then maturity. I didn't actually expatiate it because we've already spoke about it in the lecture 1. So you have to know the differences between mental health and then mental illness. Mental health is normal, that's normality, and then mental illness is abnormality. Now, under mental health, the patient or the person accepts his or herself and accepts others and appreciates nature. But for the mental illness, the patient feels inadequate and has poor self-concept. Do you see that? And then in the mental health, the patient has the ability to cope with stress or tolerate stress. But with the mental ill patient, he is unable to cope, and he even exhibits maladaptive behaviors. Like if the patient is facing financial difficulties, the patient wants someone who is mentally ill wouldn't be able to cope, or the person wouldn't be able to cope. But rather the person would exhibit some maladaptive behavior like stealing, and then convincing people to extort money from them and all of those. Under mental health, the person returns to normal functioning if temporarily disturbed. Even if the patient is depressed, maybe the person has lost a loved one. We all learned the Elizabeth Kubler-Ross grieving process, the 5 grieving process. It's in stages. So if the patient has lost the loved one and then the patient is grieving, the patient wouldn't be in the grieving process permanently, but rather it will be temporarily, and then the patient will return back to his or her normal function. But then it will become a mental illness if the patient is unable to establish a meaningful relationship, and then the patient is not able to return back to his or her normal function. Then we say the patient is mentally ill. If the patient is able to form close and lasting relationships, then that one, the patient is mentally stable. But then in the opposite way, the patient is not. And then mental health, if the person is able to solve problems for himself, but then the opposite way is mentally ill. If the patient is able to take into consideration social norms, okay, so you don't steal because you've taken into consideration social norms. We say you are mentally stable. But then, if you desire or demand immediate gratification, when you say immediate gratification, for instance, then the social norm is don't steal, and something is pressing you to go and steal. Something is pressing you to go and steal, and you go ahead to go and steal. That is mental illness. Adapt to work situation. So there is pressure, they are stressing you at work, but you're able to adapt. But then, if you are not able to adapt to work situation, if employed or if you are working, then we say you are mentally what? Challenged. Now, how can you assess the psychiatric patient? How can you assess the psychiatric patient? So, assessing a psychiatric patient is the procedure carried out to gather as much possible as information about the mentally ill patient to aid in diagnosing and treating him. So a mentally ill patient will visit your facility, just like in the OPD. What is your name? Where do you stay? Where do you work? Where do you work? What do you do? And all of those. Just past medical history, present history, socioeconomic history, obstetric history, if the patient is a female, all of those. Okay, they are nothing strange, all of those. Now, when you say mental status examination, is the sum total of observation made during a psychiatric interview. So sometimes if the mentally challenged person comes to the facility, even how the patient will appear alone can give you a clue of the patient's or the person's mental status. So a client who has worked in looking in how do you call it, talking in a bizarre way, and then wearing let's say wearing a very bright color. Okay, the patient is wearing a colors like yellow top and then red down, looking like Amos Aslim. And then the patient um, is a little bit depressed. The patient actually doesn't want to flow with you and all of those. It's that one alone will give you a clue about the kind of mental illness that the patient is suffering. Is that okay? So such patients, what comes in mind is that the patient is likely to be a schizophrenic patient. Is that okay? So we have direct inquiry about subjective symptoms, and then we have objective findings. So what I just explained is objective findings. Even before I started asking the patient question, before I even asked the patient question, I have already gotten a perception about the patient based on the objective findings or the signs I'm seeing. Almost all psychiatric diagnoses are made, at least in parts, clinically. That is, from taking a history, making observation during interview. But then, most psychiatric conditions or disorders, they are not solely diagnosed by laboratory results and all of those things as compared to the medical condition. You see, medical and surgical condition, before you diagnose, you need something like you need the laboratory results and all of those before you can diagnose. But then medical condition is not like that. From the look of the patient, how the patient is appearing, you can partly diagnose it. Is that okay? Sometimes the patient behavior, you can partly what? Diagnose it. Is that okay? So let's look at some of the data that we would need when we are when we are to diagnose or when we are to collect data from our clients to diagnose their this mental disorder. So we have the identifying data. So we have the name. So you check the patient's what? The patient's name. Is that okay? You ask for the patient's name, the patient's sex, whether a female or male. Then you also have to check for the patient's age, because we said that age can have something to do with the patient's mental status. And then also the culture and then the race. So we said that cultural standard also has or it's also a factor of the patient. Then you also check for the patient's occupation or financial status, because we also say financial status is also a factor. And then educational levels and other significant information. So let's take a look at this. Let's take a look at this. So we have the appearance alone. So this is what some of the things that you have to check in terms of the appearance alone. So the appearance alone, manic patients wear very bright and flamboyant dresses. Very what? Very bright and what? And then flamboyant dresses. They also wear rings and jewelries. The manic patients. They also wear what? Rings and then jewelries. And then schizophrenics dress in a bizarre manner, not appropriate to the occasion. So for instance, if the patient, let's say, comes in, when we say bizarre, bizarre is unaccepted way. Okay. So for example, the patient is coming to the, let's say the patient is going to a wedding. Okay. The patient is going to a wedding, and then the patient has just put on black dress. Black dress. The patient is going to, let's say, a party. Okay. A party, and then the patient will just be in, let's say, a jersey, like someone going to play a football. That is some way of how schizophrenic patients, how they behave. And then hygiene alone describes the person's neatness or dirtiness. Neatness or what? Or dirtiness. Now, if you are over neat, it's a mental condition. If you are over dirty too, it's a mental condition. So you should know all of this. So we'll be learning the obsessive compulsive disorders, the OCD. That is the disorder that talks about extremely neat and then extremely dirty. So you, depressed patient would neglect their personal hygiene and wear dark clothes. So the patient will come to your facility, a well-looking lady, having the hair all scattered, having the dress, if there is a zip, unzipped, if there are buttons, unbuttoned, wearing black cloth, you know that no, this patient is depressed. The demented and substance abusers put on soiled and stained clothing. So you look at these alcoholics, they don't care about what they wear, whether it is soiled or stained, they don't care. Religious preference, allergies. So you have to look at the religious preference, you have to look at the allergies, special diets, considerations, chief complaints, posture, even how they even sit. And then schizophrenic and anxiety patients sit at the edge of a chair. Pay attention to this. Please, this particular aspect, pay attention to it because there are lots of questions. Last year general paper, last year NMC general paper, the mental health questions were a lot. There were a lot. So schizophrenic patients and anxious patients or anxiety patients, they normally like sitting at the edge of the chair. They like sitting at the edge of the chair because if anything should happen right now, they want to kickstart running away. So they like sitting at, so we have to take note. And then the level of eye contact, especially alcohol withdrawal symptoms or alcoholic patients wouldn't keep eye contact. They wouldn't keep eye contact. Is that okay? Then evidence of scars, tattoo, or other distinguishing skin marks would also, so mostly often at times on the ward, often at times at the psychiatric unit, if a patient comes and then has tattoo, even though you don't judge the book by its cover, but then if the patient comes and have all tattoos on the skin, there is a scar on the antecubital space. You all know the antecubital space, right? Where you set your emergency line, your elbow. Yes. That's the antecubital. So there are scars all over the antecubital space. There are scars on the hands and all of those. We start suspecting that this patient is a drug addict or has been abusing drugs. in the facility, you see that this patient is always wearing long sleeves, especially if they even wear scraps. They will prefer wearing a long sleeve stretcher under the how do you call it, the scraps. Yes, you should start suspecting whether females or males. I know one female, she likes petting very well. And you look at drug dependency. Evaluation of client appearance compared with chronological age. For instance, dementia. So a patient who is around 90 years, and then the patient starts acting like a child. So you know that no, this patient is not a child. This patient is an adult. So why is he acting like a child? You know there is something wrong. Now, under the motor activities, you have to assess for tremors. Mostly tremors are associated with alcohol withdrawal symptoms. So those that the person is an alcoholic person, but then because he has relocated to a new environment where they don't sell alcohol anywhere, or he hasn't yet discovered blue kiosk or where they sell alcohol, the person will start withdrawing from the alcohol. So if they get into a withdrawal symptom, that's the delirium tremors, they will start getting tremors, shivering. So their hands will be shaking, their mouth will be shaking, their body will be twitching, and all of those. Then we have tics or other stereotypical movements. Then we have the mannerisms and then the gestures of the patient. You have to check. And then hyperactivity, restlessness or agitation. You have to assess. Aggressiveness, mentally challenged patient. Most of the mental disorders, they come with aggressiveness. Rigidity, jant patterns or jade patterns. You know jade pattern, like a drunkard. If someone is drunk, you see how the person walks. Yes. It's like the person wants to fall, but he doesn't want to fall. He's holding on onto his or herself. Psychomotor retardation, freedom of movement. Now, for the speech pattern, you have to notice slowness or rapidity of speech. So sometimes the speech will be slower than normal. Sometimes the patient will be some of the patients, they will just speak fast, 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 fast. Then pressure of speech. Sometimes when they are talking, as if they are pressuring them. Is that okay? As if they are pressuring them. And then incoherent. What the patient is saying, it doesn't fall in line with the whole statement. So you ask the patient that, where do you stay? The patient will tell you that, okay, so I went to Accra. Meanwhile, the patient stays in Accra. So you say, I went to Accra and I came to Kaswa, and then all of a sudden I started moving towards Eastern region. That's incoherent. So you look at thought disorders, you look at some of the speech disorders and all of those. You have to look at their emotions or their mood. They may be euphoric. When we say euphoric, hyperactivity, overexcited. So mostly those that are drug addicts, they have euphoric effect. They are super excited. They feel like they are high more than the most high. They are hyperactive. And then sadness and depressed is associated with depressed patient or depression. And then despairing, they feel like no one cares about them and all of those. And irritable, they feel very agitated, anxious, elated, and then fearful. Now, for the effect, you have to check in the congruence with mood, how easily their mood swings. Constricted or blunted effect. When we say blunted effect, something that you're supposed to be happy, you don't see any happiness in it. They will buy you the latest iPhone. They will give you huge amount of money. They will buy you a mansion and an expensive car. You will still see nothing exciting about it. And then their effects, you have to check for flat effect. That is no emotions, no excitement, no sadness, nothing. You are just flat. Your effect is just flat. Also appropriate or inappropriate. You also have to check for defined congruence of effects with the situation or with the client behavior. Now let's look at thought process. So what we looked at, they are the kind of history that you have to be taking, or the kind of notes that you have to be taking when a client visits your psychiatric unit. So that these ones will help you to know whether your patient is mentally okay, mentally stable, mentally ill, and all of those. Thought process. We have forms of thought. We have flight of ideas. Flight of ideas. So when we say flight of ideas, it's the thinking process whereby the patient will think very fast and no ideas are completed. So that is flight. You see, flight. Flight means fast, right? Like flight, as in aeroplane and helicopter and all those flights fast. So flight of ideas. So the patients will think very fast, but all the ideas they are not completed. So for instance, you ask the patient that, when was the last time did you eat rice? Before you ended the question, the patient has already started answering the question, but then you realize that the answer that the person will give you, it is not in relation to what you asked. So you may think the person is really thinking fast, but the outcome of the thinking is something else. And we have associative losings. Associative looseness. So that's the thinking and idea shift from one idea to the another. Example, the patient will be saying, we want to take the bus and airport took all the traffic. So the thinking and then the idea will just shift from one idea to the another. So the patient wants to say that he wants to take the bus, but all of a sudden that idea shifted to say a different thing. The airport took all the traffic. It is just like you ask the patient that, what did your child or what did your mother tell you? So my mother told me that the food was finished and the dogs started. It is not in line with. So two different ideas, shift of ideas. Then we have the circumstantiality. So for that one, the individual will delay in reaching the point of communication because he will give you unnecessary details. But then at the end, the patient would actually get to wherever he is talking or whatever he's saying. Is that okay? So when we say the circumstantiality, for instance, so we say the individual is delayed in reaching the point of a communication because of unnecessarily and tedious details. So they will ask you that, where do you stay? Where do you stay? Now the patient will start narrating his life story, and then we'll go and end at where he stays. It doesn't make sense. So that is circumstantiality. And then we have the tangentiality. That one is different from the circumstantiality because the person or the people never delay getting to the point of communication. So once you ask, the patient would give you the right answer, but the patient will be jumping. For instance, so what happened that you started eating the rice? So instead of the patient, ideally the patient will tell you what's really happened and order before he ended up eating the rice. No, the patient will rather conclude that, yes, I ate the rice. That's the tangentiality. Yes, I ate the rice. But the circumstantiality patient will give you a full book of explanation before he will end that. So that is why I ate the rice. Have you gotten the two difference? Then unrelated topics are introduced and the original discussion is lost. So that's the tangentiality. So we have the neologism. For the neologism people, they will just be, telling you the story or they will be communicating with you, but then they will be using some big terminologies which has no meaning. It's only meaningful to them. So they will just mention a certain term. For instance, she wanted to give me a ride in her uniform. What is uniform? So you just be asking yourself, what is uniform? What you go and search that word you never find that word. It doesn't exist, but it is meaningful to them. It's them that they understand what they are saying. So, and then we have concrete thinking. That's concreteness or literal interpretation of the environment, present or regression to an earlier level of cognitive development. So they will be giving a description of certain things in a certain way that no one understands. It's different from the neologism. For the neologisms, that one they try to give big terms. That's a neologism. So you have to pay attention to this thought process too. Questions would pop up from there. So pay attention to it. So there will be a description of a certain patient, and then so it will be quote unquote. A psychiatric or a patient or a client visited your psychiatric unit and was complaining of so and so and so and so. In assessing the client's thoughts, the patient stated that, let's say, she wanted to give me a ride in her euphorium. As a psychiatric health nurse or as a nurse, what type of or what thought process would you use to describe your client statements? Neologisms. So you have to take notes. We have clang associations. Clang. So the choices of words is governed by sounds and often take the form rhythms. So for those people, they will try to communicate with you, but then it's like they are rhyming. It's like, oh, they are rhyming. So mostly the clang association, their choice of words is governed by sounds and they often rhyme. So all these rappers and all these rhyming people and all those, it's it's mental illness, but then they don't know. So you take it like that. So for example, it is very cold, I am cold and bold. So you see how it is rhyming. The gold has been sold. So what you ask them, that is not what they are saying. They are trying to put words together for it to rhyme, for you to feel happy. That is all. Then we have word salad. You know what salad is? Salad is a combination of different type of what? Vegetables and fruits and all of those. So yes, word salad. So they are a group of words that are strung together in random fashion without any logical connecting. It doesn't make sense. They will just be saying it. For instance, the client will just come and then he will start saying, your client will come and then he will start saying, most forward action, gross life, double play, circle, uniform. It doesn't make sense. He's just conjuring the words. He's just combining two or more words together, just like you are preparing salad. You see, so that is how mostly that one looks like. All right, so someone is asking or someone is having a concern in the comment section. So let me quickly read it. Then after that I'll read it and then proceed so that I don't disturb the class. And we have preservation. So please drop your comment section. I'll read it after the class for clarifications and all of those. So we have preservation. So the individual persistently repeats the same word or idea in response to different questions. So you ask the patient, have you eaten? He will say, okay. Why are you here? He will say, okay. Who brought you here? He will say, okay. What did you eat in the morning? He will say, okay. Why were you going there? He will say, okay. Persistently repeat the same word or idea in response to different questions that you ask him, but he's still giving you the same answer to those many questions. That is preservation. He's trying to preserve what he's saying. Then we have mutism. That's poverty of speech. You see, something will just happen there and you say, I have even lost speech. I am short of words, right? That's what you normally say. So that's restriction in the amount of speech. You can't even talk. That's mutism. Mute. So mutism. Then we have ability to concentrate, attention span, content of thoughts, and all of those. We have delusions. It's also so these ones are perception disorders. Is that okay? So we have perception disorders. So we are done with the thought disorders or forms of thought. We are done. So let's move on to perception disorders. Perception disorders. So the first perception disorders That or yes, perception disorders that we are talking about is delusions. So we have delusions, you've heard of illusions, you've heard of hallucinations. So those are the perception disorders that we are talking about. So let's start from delusions. Delusions. When we say delusions, sorry, it's not delusions, it's delusions. Okay. So when we say delusions, these are false personal beliefs that are inconsistent with the person's intelligence or background and cannot be changed. Pay attention very carefully to these stereotypes because there are some scenario questions which may confuse you. So pay attention. After that, I'll give you examples of them for you to understand it very well. Okay. So delusions, these are false perception beliefs that are inconsistent with the person's intelligence or background and cannot be changed. So they are false personal beliefs. For instance, a patient will say, "My mother is a witch. My mother is a witch." So this becomes a delusion because it is a false. But ideally, the mother is not a witch, okay? But he strongly believes. So it comes a strong belief of something, a strong belief that something exists, or something is happening, or someone is something. Like my mother is a witch. That is it. That's a false perception, and they are inconsistent with the person's intelligence or background and cannot be changed. No matter what, even if Jesus Christ comes down to come and tell him that your mother is not a witch, he still stand on that ground by saying my mother is a witch. So that's the what? A delusion. A delusion. So the delusion comes with what? With false or belief. Those that are dropping their questions in the comment section, I would answer them. Is that okay? I would answer them. So keep dropping your questions in the comment section. I would answer it after the class. So that's delusion. That comes to the false personal beliefs. So if the patient comes and then there is a description of these patients, and then the patient states that the hospital is a place of no return. It's a belief. He believes that the hospital is a place of no return. Even if the Minister of Health comes to tell him that the hospital is where you will be saved, he won't believe it. The hospital is a place of no return. Don't take me to the hospital. Don't take me to. It's a place of no return. It's a false what? Personal belief. So it's what? So note that delusion comes with false beliefs. We have types of delusions. We have the persecutory. So for that one, the individual feels threatened and believes that others intend to harm them. Is that okay? For instance, they'll just be there and then they'll just have this belief that the police just barged into their house, or the police so you'll be like, the police just barged into my room and then they wanted to kill me. Meanwhile, no police has even come to his house before, but he has this belief. He just have what? This belief that the police has barged into his or her room and then they wanted to kill him. So that's persecutory. They feel that someone wants to persecute them, someone wants to attack them, someone wants to what? Threaten them. Is that okay? Then we have grandiosity or grandiosity. So for that one, the individual would just exaggerate some feeling of importance or power. So the person is just like you and I, but the person will be feeling like he's the creator of the universe. For instance, someone will just stand up, I am Jesus Christ. Someone will just get up, I am the president. No matter what, I am the, with strong belief that I am the president. Meanwhile, you are not. That's grandiosity. Grandiose. You are feeling, you have that gut. You have that power. That's grandiosity. Is that okay? And then we have control or influence. So these people, they always believe that certain objects have control over their lives. So those people, they always visit pastors, they always visit fetish priests, they always visit spiritual people. They think something is controlling their lives, something is making them not to succeed in life. That's control or influence. It's a type of delusion, and it's a mental illness. You see, if you take time to learn mental health, you consider everything as mental illness. So that is control or influence. We have somatic. Somatic is also a delusion. It's also a type of delusion. So the somatic, that one, the patient will have a false idea about the function of his body parts. You will see the hand there, but he will tell you that my hand doesn't exist. Mostly it happens to the men. They will tell you that they feel like their penis is not working anymore. So a patient will just come and tell you that I am 70 I am 70 years old and I will be the oldest person ever to give birth. The doctor says I am not pregnant, but I know I am. So you have some false belief about function or of his body. So this bounce back to religion, whereby the doctor says you've been diagnosed of cancer. Then you go to your church and then your pastor will tell you you are not having cancer. Then you have this belief that I don't have cancer. I don't have cancer. That's a mental disorder. Or your doctor will tell you that, oh, so because of this condition, so you can't get pregnant. Then you go to your pastor, then your pastor will tell you that have faith, you will get pregnant. Then you have this kind of strong belief that even though the doctor says I'm not pregnant, but I know I am pregnant. That's a mental disorder. So you see, a lot of things that you may think it's normal, it's actually mental disorder. But don't forget that factors that determine normal from abnormality, we say that was the cultural context. So for all what you know, maybe in your cultural belief, in the context of your church belief, that one is not a mental illness for you, or that one is a normality for you, then it's not a mental illness for you. But if my cultural belief says that those things, you don't have to believe in those things. For me, I will see it as a mental illness, but you won't see it as mental illness. So I'm not saying that if you have faith in your pastor or in whatever you believe in, it's a mental illness. No. While we are learning it, then you'll be linking it up with the causes of or determinants of normalities and then abnormality. The next point here is nihilistic. So that one, the clients would have a false idea that the self or a part of self or the world doesn't exist. So those people will tell you that there is no Jesus Christ. The world doesn't exist. Some people they can even go to the extent and tell you that I am dead. While I am walking, I am dead. I am dead, but I'm living. They will even tell you that I have no heart. They can go into strict arguments that they don't have heart. They don't have stomach. They've been saying that there is God, there is no God, there is no God, no one like that exists. No. That's nihilistic. Then we have religiosity. An excessive demonstration or obsession with religious ideas and behavior. So those people will tell you that Christianity is fake, Islamic religion is fake, traditionalist is fake. This is fake. God doesn't exist. Allah doesn't exist. There's nothing like Allah. There's nothing like God. All those people, that is religiosity. But for their own, it becomes a mental disorder if it persists. If even they've explained to you and you are refusing to understand, you are refusing to understand the fact, you are still standing at where you are standing. That is when it becomes a mental illness. So the second one is hallucination. So hallucination has to do with your perception. Is that okay? So they are false sensory perception. not associated with real external stimuli. Is that okay? You are hallucinating. Remember, the delusion is what? Is a belief. But then the hallucination, they are sensory perception. So you are seeing the thing, like you are perceiving the thing, okay? You are perceiving the thing to be in existence, but it doesn't associate or it has no relation with real external. When we say external stimuli, something that you can touch and feel. So you just be hallucinating. Then you just be perceiving that that bird that is flying is an aeroplane. So you see the bird flying. So he will see a bird flying, then he will say that that is an aeroplane. You are having a false sensory perception of aeroplane, but then in reality, it's not aeroplane that is passing, but it's a bird. Sometimes you would even see only you are seeing that kind of aeroplane. You are the only person seeing aeroplane passing, but in real external stimuli, there is nothing of that sort passing. You see, that's hallucinating. So it's mostly common in patients with alcoholism, patients with alcohol intoxication, patients with alcohol withdrawal symptoms. They'll come to the hospital, they'll just be hallucinating. They'll just be there, then they'll say that, hey, see the doctor going, but no doctor to his person. So they will be having false sensory perception. They'll be perceiving something false, but then in reality, it's not there. Sometimes it can be in the form of visual. They'll be see the aeroplane, but there's no aeroplane passing. Auditory, I can hear people talking, I can hear people clapping, I can hear people singing, but in reality, there is nothing like that. I can hear people touching me. I can hear someone pulling my hand. Sorry, I can feel someone pulling my hand, but in reality, no one is pulling anyone's hand. Olfactory, they'll be smelling something. I can perceive a very nice smell, but then in reality, no one else can perceive that smell apart from only him. Gustatory, I can taste, I can taste this, I can taste that. For instance, we will give him orange, and only him, instead of him to be tasting the orange, only him, he'll be tasting strawberry. That's a gustatory. Then we have illusion. Illusion. So illusion has to do with misinterpretation of real external stimuli. So sorry, the example that I gave, the bird and then the aeroplane will rather fall under illusion. Is that okay? Illusion, whereby you be misinterpretation of real stimuli, real external stimuli. So you will see a bird and you will mistake it for aeroplane. But for the hallucination, there is nothing passing, but you are seeing something passing. There is nothing passing, but you are saying there is an aeroplane passing. That's the hallucination. But then in the illusion, there is a bird passing and you are mistaking the bird for an aeroplane. There is a belt on the floor and you are mistaking the belt for a snake. There is there is a stone on the floor and you are mistaking the stone for gold. That's illusion. There is a tree in your community and you are mistaking the tree for a different thing else. That's illusion. It could be in the form of deja vu, already seen. Jamais vu, depersonalization, derealization, sensorium, level of alteredness, and all of those. Perception disorder, they are still on it. So if a patient comes with a perception disorder, you have to orient the patient to time, because the patient that is coming with hallucination, he's telling you that I am seeing stars, I am seeing the moon. So you have to orient the patient time. Ask the patient, which time are you, or are we in the morning, are we in the afternoon? Orient the patient to place. Ask the patient, which place are you? For all what you know, the patient is seeing the whole place as a nightclub. Meanwhile, it is a hospital. Orient the patient to person. For all what you know, the patient is seeing everybody. The patient with hallucination is seeing everybody in the hospital as yam, or as toys, or as teletubbies. Circumstance, memory, and all of those. confabulation. The patient will just be conjuring words, talking anyhow, talking their mind, which even doesn't make sense. The ability to control impulses related to aggression. So you have to check the patient's aggression, hospitality, fear, guilt, and all of those. Sexual feelings, judgments, the ability to solve problems. You have to assess for all of these. You also have to, so we have knowledge about self. So we have awareness of limitation. You have to assess. We have awareness of consequences of actions, awareness of illness. Now, if you are having a conversation with a mentally ill patient who is not aggressive, you don't make the patient to feel guilty. You don't have to make the patient to feel guilty. Is that okay? You have to make the patient to know that it is not her fault. For instance, if you are counseling a young lady who has been raped, you don't have to make the patient feel guilty by telling the patient that you shouldn't have worn that short skirt. You make the patient feel guilty, and the patient will be more traumatized and more depressed. But rather, you have to make the patient know that it is not her fault. So, psychiatric history, we have the chief complaints. Those are the main complaints that the patient will tell you for which he is there. And for that one, you have to provide the reason that the patient is seeking care using the patient's own words in quotation marks. So, unquote and unquote, I've been experiencing tremors, quote and unquote. My wife has divorced me, so I've been depressed, quote and unquote. That's how you write the chief complaints. And we have history of presenting illness. So you have to document current signs and symptoms, describe the symptoms, and if you are describing the symptoms, you have to use the terms that the patient is saying. So it's being described by the patient. So if the patient was saying that I was seeing, or I've been seeing stars in the sky during the day, you should state it. Okay, so someone has dropped another question. I would look into that. That's the chief what? That's the history of presenting complaint. You explain it in the patient's own words. Then we have past psychiatric history. So has the patient been hospitalized based on any surgical or medical condition before, or any mental condition before? Has the patient been diagnosed of any mental illness? Has the patient been treated, and all of those? Substance abuse history. Do you take alcohol? Do you take cocaine? Do you take marijuana, amphetamine, barbiturates, and all of those? Social history. Development history, if relevant. So you know social history. And then the family history too. You have to take notes. And the kind of medication, whether present or past medication history. The patient has taken any psychiatric medication before, antipsychotics, anxiolytics, antidepressants, sedatives. Has he? You have to assess for the mental status of the patient. Then now you come to the diagnosis. So diagnosis is made across 5 separate axes to delineate primary psychiatric disorders and substance. So this particular one is a full lesson on its own. So for the diagnosis, you have to determine whether your patient's signs and symptoms or the patient's history that you've taken, it is in line with a primary psychiatric disorder, or it is in line with substance abuse, or it is in line with personality disorders, or it is in line with mental retardation, or it is in line with general medical illness, or it is in line with global functioning, or whatever. So we will look at mental disorders. It's a lot. All the disorders, it is a mental disorder that has broad categories. So we will look at the neurological disorders. We will look at the neurological psychosis, functional psychosis, retardation disorder. That's the mental retardation. We will look at obsessive compulsive disorders. We will look at post-traumatic disorders, anxiety disorders. There are a lot. So the diagnosis will come. These ones are general nursing management of mental disorder. Now, take note that the general nursing management, we have the physical care. The physical care, which is more or less like any other care for the nursings. So, personal hygiene, rest and sleep, ensure elimination, maintain nutrition and then fluids, provide protection and safety, ensure exercise, and then all of those. And we have the psychological care, establish rapport and good relationship. You do this to allay anxiety and then to also make the patient to feel that he or she is in the hands of competent nursing care. That's the rationale for establishing rapport and good relationship. Because once the client comes and then you don't even establish rapport, you are not even friendly. The clients will not feel safe to give you the necessary information that you need. You also have to reassure your clients that they are in the hands of safe or competent health team, and then their signs and symptoms will be alleviated. You have to provide encouragement. Like I said, don't make the client to feel guilty. You have to orient patients due to loss of memory and then hallucination. So that is the rationale for orienting your patients. You remember, you orient your patient to sign, place, people. Observe clients always, so that the client, you always make sure that your client is safe. You know what is happening to your client. Address clients by his or her name. It is the client's right to be addressed by his or her name. Listen to patient's views and guide him or her. So you have to listen to your patient's views and guide. So the rationale being that in facilities, we assist the patient to gain speedy recovery. Remember, definition for nursing, according to Virginia Henderson, you assist the patient, the able patient, quote unquote, the able patient to gain their recovery. Provide emotional support to clients. Educate clients and family members about cause and prevention of the mental illness. Interview client to assess his mental status or level of reasoning. Give psychotherapy or counseling. Offer recreational therapies. You also teach the family how they, or there's some of the things that they can do to support the client in gaining his recovery. So this is the end of the lecture 2. This is the end of the lecture 2. In our next lectures, we shall look at the lecture 3 of mental health. So for now, I would like to take questions.